nǹkan tí ó ṣe àmàrí. Ah, wọn ò ready ẹ mọ̀ pé ìyẹn máa ṣe camera and everything. Sáwọ́dì máa fọ́ọ̀dù nǹkan sí nísìn kí ẹ sáré fún mi fún un. Nọ́mbà òní kí sẹ́ni lọ sí. Boss. Kí ni ìdí ẹ̀ o? Tẹ́lẹ̀ kà fẹ́ mi báyìí.
ẹ ò fẹ́ fún mi ẹ jẹ́ màá send ẹ̀ sí wọn ní WhatsApp instead of tí mo fi máa. kò wá padà. Hi, good evening, beautiful people. Blood talk, genotype, compatibility, and Rhesus factor. What everybody should know. I am Fashola and Marie Yewande. I will be your moderator tonight. We're about to dive into something truly eye-opening, and yes, everyone should be involved. Everyone should know when should know about blood. And also, before we kickstart things, I would like to say
Good evening, everybody. Can I be heard? Good evening. If you can hear me, please chat in the chat box. Let me know if I can be heard. Good morning, good evening, rather. Good evening, everyone. Hope our day was great. We have a little network glitch, so our moderator is not here right now. She'll join us soon. So I'll be doing the work of the moderator and the host. Yeah. So we're about starting. You're welcome to another webinar. Last month we talked about hypertension. You can still find the audio recording on this page. Um, while we wait for other people to join, please share the link. Share the link. Share the link. This topic is a very important topic that everybody should be aware of. That everybody should know what your genotype is, what your resource factor is, ABO compatibility, and what have you. So it is a very important topic that we are discussing tonight. So I want you to share the link to your friends, to your family, to everybody around you. So can we hear me? Okay, thank you, Miss Convenance. She said I can be heard. Um, just as I rightly said, our moderator is our network is quite bad. So good evening, everyone. I am Badaki Roda Mutsorayo. I am a registered nurse, registered midwife, registered public health nurse. My interests are in public speaking, health education, and taking healthcare to the grassroots. So this evening we'll be talking about genotype and rhesus compatibility, everything that you should know. And we have a seasoned guest with us tonight, Dr. Akitola Akinwumi. So before I read his bio and welcome him up on stage, I would again want to tell you a little about Team Favorite Nurse, what Team Favorite Nurse is about. Team Favorite Nurse was started around 2020, 2021, and it was started with me and my other team members. We started like I started because I wanted to do something. I wanted to impact my village. Hmm, what to do? Sorry, there was another can I still be heard? Okay, so Timber was started 2020 2021, and it was as a result of a passion that was born out of, oh, I wanted to do something, even as a student, because then you have to have a license because before you can start anything reasonable. Then I just felt like, let me start community outreach. Let me start by going to schools, educating the girl child, um, and even the community, and even the community. So that's how To Be Right Nurse started, and now currently we have about more than 20 volunteers for the team. Isn't that a great achievement? Yeah. Thank you all so much for joining again. So I would be I would be reading. So I'm trying to see if I can add back the moderator. Our network is quite something somehow. So let me see. Okay, we already have our guest speaker. So let me just quickly read his bio. Don't let me bore us with much talk. Dr. Akintola Akiwumi is a resident doctor specializing in hematology and blood transfusion services at the University of Ilorin Teaching Hospital, where he has been honing his clinical expertise since February 2024. He holds a bachelor's degree of medicine and he holds a Bachelor of Medicine and Bachelor of Surgery from the University of Ilorin, which he completed in 2021. Dr. Akitola's academic journey is complemented by a commitment to continuous learning and professional development. He has completed several special courses, including certifications in biomedical research from the Center for Bioethics and Research in 2023, cancer biology from Johns Hopkins University, and immunology from Rice University. His interests in public health are evident in his certification in epidemiology and COVID-19 from prominent institutions such as Johns Hopkins University and the London School of Hygiene and Tropical Medicine. In addition to his clinical training, Dr. Akiwumi has engaged in business and leadership education with certifications in procurement, business management, and leadership from respected institutions. He has a strong passion for community service, demonstrated through his volunteer work with the Whitetail Foundation Research Group, where he helps raise awareness about blood malignancies. He also he has also been an active member of the Christian Medical and Dental Association of Nigeria, contributing to the medical outreach programs that provide free healthcare in rural areas. His leadership capabilities were recognized were recognized Okay, his leadership capabilities were recognized through various awards, including the Social Impact Award from the United Nations Academic Impact and Millennium Campus Network in 2019. Dr. Akinwumi's dedication to advancing medical knowledge, improving patient care, and fostering community health initiatives make him a valuable asset to the medical field. His diverse skill set in both clinical medicine and leadership, coupled with his commitment to lifelong learning, positions him as a future leader in healthcare and public health sectors. That was so powerful, so wonderful. We're so grateful to have you this evening, Dr. Akintola Akiwumi. You have the
Yeah,
stage,
thank
sir.
you.
Thank you so much, sir.
Oh,
Please let's
all
welcome him
right.
in the chat.
All right. Thank you so much. Can I be heard? Am I holding well enough?
Yes, sir, you can be heard.
All right. Thank you so very much. Thank you for this privilege. Thank you for inviting me to bring this set of discussions today. And I want to say well done, well done, well done, well done to you and the team. I think I got to the point where you say you now have 20 team members. I mean, that's a whole lot. If you have 20 team members, I mean, that's a great job. And we can only believe that this is the beginning of very, very, very great things. So, thank you once again to the team for having me. So, what we have before us this evening is genotype compatibility and Rhesus factor, what everyone should know. And I just must say this as a beginning. You know, going through medical school and doing housemanship service, and now in the specialized training. I remember one of those days when we had a patient in school. I mean, you could just imagine the pain in the eye of this young chap, and the pain, the terror. But you wouldn't imagine that this child at some point started cursing the parent. I mean, it started insulting the parent. And I'm wondering, I mean, the child was wondering since they knew or they didn't know, but of course, the parents claimed that they didn't know, or some things happened. And that sight was not palatable. You can imagine a young chap crying in pains, in rigor, in pains, and all sort. And then at some point could not cope with the pain, saying all sort to the parent, and the parent were just looking helpless. And also on the otherwise, I met another patient while in residency who came blaming everybody that they did it before, the people that told them that she was this, but unfortunately, when they got married and started giving birth to children, it was the other way around. So most likely, maybe the hospital they use or the clinic they use gave them a wrong result. And because of some of these lapses here and there, it's very important that everybody. I mean, I don't think that this subject should be for only medical professionals. I mean, it should be something that is discussed even in the marketplace, and that's why I was interested in taking up this opportunity to enlighten the public space. And I'm willing to do that again and again, even on larger platforms, because just like hypertension, as she rightly said the last time, now there are several things that we don't need to keep within the medical box again. We have to commit some of this information, even to the layman, so that we can save many, so that we can preserve many, so that we can avoid a number of complications and a number of heartaches and breaks, that we are seeing among the people. So I think I came up. We have some slide here that we can just use to just to flow together. And don't forget that this is my primary department. I mean, I'm in dermatology. So asking me to talk about compatibility is just like throwing me into my menu. So you can be sure that I can speak from now till next step. Of course, I'll be short. So I'm going to be giving just some snippet. I don't know if it's time for question or it's just a live broadcast without a question, but that'll be fine.
Yes, there
So,
there is a time for questions and answer at the end, sir. And I won't be able to share the
oh, okay.
slide because yeah, I have an issue with my phone. I am to use my laptop. It's not currently here with me. So I'll just send it to our general group. We have a general group on WhatsApp. I'll
Okay,
share
all
it.
right.
Yeah.
All right, no,
Thank
no,
you,
no,
sir.
it's just fine. Maybe if you record the video, someone can edit and put the slide at some point. It's okay. So,
Okay.
when we say genotype, what do we mean? The word genotype, the key word there is gene. Gene from is genetic. And when we say genetic, I mean, it's not something you can influence. I mean, influence in the sense that when we say genetic, it's your makeup. It's molecular. There's nothing or little one can do about it. So when we say genotype, we're talking about the genetic makeup of an individual. But this makeup, they are inherited from both parents. So I'm sure that some of you know that to have a child, husband and wife must come together. Of course, in a more polarized world now, they will argue that how that no, you don't need a husband, but let's leave that from the discussion. So you need father and mother. So the two coming together, half from your 50% from the mother, 50% from the father, they come together to produce a child. If it's excess, it's what? It's a female. If it's XY, it's a male. Now, so those chromosomes contain genes. So 50-50%. So the makeup of anybody is genetic material from both parents, and it defines how the red cells are formed and how they function. So which you are going to see later on. So this genetic makeup determines many things. It's not just red cells now, but for our discussion, it determines how the red cells are formed and determines the antigens and a lot of other issues around it. So genotype is not something, and this is important because sometimes people feel that by using an herbal drug, they can change the genotype. That's not essentially true. It's gene, it's molecular. So if anything will change anybody's genotype at all, it has to be done at the molecular level. I mean, and of course, so in medicine, you have gene editing, you have a number of things that we do now in medicine, hematology, just to because to change that is at is molecular. So when you see somebody with a particular genotype, yeah, I want us to be educated and not to waste your money on people who say they are selling this, selling that to change. It's genetic. It has been there since we were born. It's not something that you then change when you grow up, except we go to the molecular level. So knowing one's genotype is essential before marriage or having children to avoid the risk of serious hereditary blood disease. Of course, like the common one that we have is the sickle cell disease, which is what is more common. Of course, there are some other ones, but what is more common, what is more debilitating, is more of the sickle cell disease. And just a way of bringing of some knowledge, sort of, uh, they are quite there are more than five genotypes. I mean, there are more than five of them, but in the slide I have with me, we just put five most common genotype. In some text, you have genotype OO, but which is not what you see regularly around here. So there are five common genotypes, and the five you have AA genotype. Now, don't forget what I said. Now, this genotype is inherited from both parents. So just imagine I say AA now. AA means that A from the father, A from the mother. So if you see anybody with any abnormal genotype, abnormal in the sense that that's not how the cell looks like. Don't worry, I'm going to explain everything in a bit. So we have five common genotypes. We have the AA, now which is the normal hemoglobin. In every red cell, I mean in a red cell, red cells are other please now. Red cells they are by concave. Now in these red cells, there's something inside called hemoglobin. So hemoglobin is what carries oxygen. You know, is what carries the oxygen from around the body. So when you breathe in, breathe out, in the lungs, oxygen gets into the blood. Now, what carries that oxygen to the tissue level, then cellular level, is the red cells. And the shape of that red cell is very important. It's very, very important. So if the shape is normal, it will work normally. If the shape is not normal, one, it will not provide what it should. It will not. What's the word? It will not do what it's supposed to do. Meaning that it will not saturate. It will not carry oxygen as expected at the level it's meant to do. Number two is that because it's also an abnormal cell, is going to cause a lot of trouble, which you are going to see later on. Now, so we have the normal hemoglobin AA, we have AS. AS means that there's a normal hemoglobin, there's a normal red cell. Now, but in S, now there's an abnormal red cell. It's sickled, something has happened. And in medicine, we call it a point mutation, but don't bother yourself with that. It's a mutation, it's a molecular defect. As I was saying, it's a genetic defect. So it's not something that you do simply because it's not something that someone has because he offended somebody. No, it's not an attack, really. It's genetic, it's something inherited. So we have SS. SS is that there's a sickle cell inherited from the father and a sickle cell inherited from the mother. There's AC. It is AC, A from the father or mother, C from, and there's SC. No, so these are, we are what we call sickle cell disease. We are what we call sickle cell trait. Now, trait is anybody that has AS, that has SC. Those are sickle cell traits. You know what I'm saying now? But when we say sickle cell disease is that the person has a double S. So a trait is that there is an abnormal hemoglobin one. It's two now. A. So the one is abnormal, one is normal. But that's the trait. And people that have sickle cell trait, uh, a number of them, like the AS, they are basically fine until they're basically fine. There's no problem. The only problem will come when you want to get married or some other thing. People with HC, of course, HC is a variant. It's a sickle cell variant, not a disease. It's not a sickle cell disease, it's a variant. But HC also has its own complications, its own issues, just like the SS. But SS is said to be more severe in terms of its clinical signs and symptoms. HC2 has its own, but relatively SC can be stable and may not have issues until some other time. Sometimes even the old age, they don't even know because they are relatively fine compared to SS that at anything, extreme temperature, extreme cold, sicknesses, anything, they're just down with bone pains, difficulty with breathing, sometimes stroke if not well attended to. So five common genotypes you see around AA, AS, SS, AC, and the SC variant. Now, just because of what we are discussing here, our topic says that genotype compatibility. Now, before we talk about compatibility, I think what I also want to say is that broadly, you know, everybody has blood in his body. So, uh, different school of thoughts, but about 5 to 6 liters thereabout is the estimate of what is in the body. 5 to 6 liters thereabout. Now, this blood is made up of red cells. So, these cells, I've told you about time, these are red cells. These and there are other cells in the body, red cells, white blood cells, platelets, and the likes of them. Good. Now, these cells, they have what you call antigens. That is, there's something on the cells that coats these cells, and they are different for each person. I mean, it's not everybody does not have the same antigen. So now this is what we're talking about. So broadly speaking, we have two. We are so we all say blood group and genotype. Now, genotype, I said earlier on, is genetic. I mean, genetic, meaning that it's a makeup. That is genotype. Now, for everybody who has a blood, who has red cells, there's what we call blood group. Now, blood group, some things are interesting. God is it's wonderful. Now, these cells they have antigens on their on their surface. Now, these antigens, what they do is that it's like see, they are sensitive to anything that is apart from that antigen on that cell. It's like somebody, it's like a defense to say that nothing comes there. So these cells have antigens that coats them. Now, because of these antigens, we have what we call blood group. So blood group is actually talking about different groups, groups with its antigens. And it is important because if you don't know, if that knowledge is not there, there are consequences. Don't forget, I'll come and talk about compatibility with genotype, but I want to marry genotype and the whole group together, if that will make some sense. So we are what to call blood groups. So we have two basic or two more most common. There are many types, but the two most common we have ABO, blood group system, and the Rhesus system. Now, Rhesus is that, genotype is AS, AC, SC, SS. That's five common. In blood group, someone can be, we have blood group A, blood group B, blood group O. That is the ABO classification. And that is one of the most common. I mean, it's the most common. You will find it in almost anybody. You have Kelly, you have Dread. Those ones are rare. And so clinically, we don't focus on such except in some conditions. But ABO is common. So I'm sure you have heard someone say blood group O, blood group A, blood group B, and blood group AB. So A, B, AB, and O. But secondly, is that we have what you call the Rhesus system. Now, unlike what I said earlier on, this ABO is very common and it is naturally occurring. Naturally occurring means that there's nothing you did to have that. Hear me clearly. So someone has blood group A, blood group B, blood group AB, blood group O. There's nothing you did. It's I mean it's genetics. I mean it's nothing you did. The antigens they are formed early, even before, even as early as when you're an infant. There are many hypotheses around that, but don't bother yourself with that. So these are naturally occurring. But so naturally occur both ABO and Rhesus, they are naturally occurring. Now, but the matter of compatibility here is that even though they are naturally occurring, in each person, it is different. It is not the same. For example, now, uh, my own blood group may not be the same blood group with the team lead, Sister Rhoda, may not be the same blood group with her. You get what I'm saying now? So everybody has different blood groups based on our genetics, based on the composition from our parent. I don't know if that's clear. So each of these group, in this blood group system, the two major ones, ABO and the Rhesus, everybody has it. Now, all these blood groups I'm talking about, they have antigens. I said it before, they have something that coats their hair. What is then important here is that because we don't all have the same blood group, and because all these groups they have different antigens, that then means that there can be issues when somebody gets a wrong blood that is different from his or her own. So let me assume that that is a bit clear. So I will come back to that. So for compatibility now, we all know from the genotype I've talked about, there are things that they are what's the word now? There are people who are compatible. And now, for that AA to AA, of course, that's fine. Now, why is it fine? Because the red cells are fine. AA and AS, they are compatible. Why are they compatible? Because don't forget that it is 1-1. So if everybody has two, somebody has AA, somebody has AS. No matter how you cross it, just link it together. If you do crossing, the worst you can have is 50% AS. You can, that is what the worst you can have. And when someone has AS, there's no problem. The person is otherwise very fine. Of course, there could be secret cell, but they are not secret enough to be of any importance. Of course, AA and SS. A and SS, it could be a bit risky. Risky because when they marry, they produce only SS because there's no other A there. And of course, you have AS, AS, AS. AS then marry AS. So no. So, but if AA and ASS marry, there wouldn't be a problem. The children will have AS, 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 and they'll be otherwise fine. But so the other was fine. But why we say it's risky is that if it is possible to be prevented, fine. But if not, it's okay. I mean, the children will have no problem and they will live in normal. They will only be advised that they must be careful of who they choose later on. Now, when you have AS with AS, that is not advised. But for the sake of this live stream, let me say to you, it is not advised. But if you're intelligent, and sorry, I mean we're all intelligent, sorry for that. We're all intelligent, and you remember what I said the other time about the crossing. Now, it's not as if when AS and AS marry, they will produce only SS. That's not the entire truth because sometimes when you don't give people the whole spectrum of truth, they believe a lie. Now, I wish I have a board to write to you to see. Now, so AS to AS, the challenge is that they will have 50% AS, 25% AA, and 25% SS. But don't forget, this 25% we're talking about is not as if The body will say, okay, you will not pick one. In fact, you have seen people who all their children are SS. So it's not a risk to take. It's not advised in any medical platform because the body can choose. The one that will move, the one that will be donated by each parent can actually be SS. And of course, you know the problem of SS. One, because of the bad sickle cell, that cell, because now, I don't know if you can see my hand, this a normal cell is biconcave. Now, a sickle cell is sickled, like this. You have to my hand. I don't know if you can see my hand. It's sickled. Because it's sickled, it cannot pass through the blood vessels very well. And so it occludes capillaries, it occludes end arteries. That's why they have pains in their bones, they have pains in their joint, they have priapism, they have pains in their abdomen because those cells, when they want to pass through the vessels, they occlude. And if you're not careful, you could even cause ischemia and a lot of complications that you can always read up online. So it's not advisable. AS and SS, it is dangerous. I mean, it is 50% AS, 50% SS. So you can imagine, I said for AS to AS, 25%, if it's even a risk, talk less of when you now have 50% risk score, it is not advisable. SS and SS, it is colossal damage, colossal damage. That's what I want to use. Of course, you know that urge there will be SS. So those who are compatible AA with AA with AS, AA and SS, that's fine. But AS to AS, AS to SS, they are not advisable, they are not compatible, and they are not advised. So, as I was saying the other time about blood groups, now blood groups also has its own compatibility. Now, what does this mean? And how is this important? Now, it's important because of blood donation. Now, because blood donation and also in females who get in females of pregnancy. Now, don't forget I said that each of these cells they have antigen. The most common of them is the ABO system and the Rhesus D system. Now, for ABO, we have blood group A, blood group B, blood group AB, and blood group O. Now, for A has antigen A. That's why it's A. B has antigen B. AB has antigen AB. O does not have any antigen. O. Now, because of that antigen, naturally, they already build antibodies against what they don't have. So what do I mean? You know, A now has antigen A. By default, it has antibody B, meaning that if someone that has blood group A can, let's go this way to make it easy. So blood group A has antigen A and antibody B. Blood group B has antigen B. Blood group AB has antigen AB. Blood group O, no antigen. So blood group A, we have antibody B. Blood group B, we have antibody A. Don't forget. Now, blood group AB, it has antigen AB. So it will have what? It will have antibody. I don't know if you can understand now. It will have antibody. So sorry. I mean, because it has antigen A, antigen B, it will not have any antibody. I don't know if that's clear now. It will have no antibody at all because you can't have antibody against what you already have. If you do, it's dead. I mean, it means the body will fight itself. So blood group AB, they don't have any antibody. They have no antibody because they are both antigens. Now, blood group O does not have any antigen, but as what? Has both antibodies. Antibody A, antibody B. So what does that mean? Meaning that somebody with blood group A cannot get any other blood. In fact, you can't give the person AB or B. The person can only collect blood group A and what? And what? And O. I don't know what I'm saying now. So somebody because if you give the person already has antibody B. You can't give the person B, right? And you can't give the person AB. If you do, if you give AB, which is antigen B, person already has antibody B. So there'll be trouble. There'll be what we call hemolytic reaction. So in the same way, somebody with antibody with a blood group B has antigen B cannot get blood from someone with blood group A or blood group AB except B and O. In the same way, someone with blood group AB, AB has both antigens. That's both antigens. So what therefore means that someone with AB can accept everything. Someone with AB can accept everything. I mean, it's a universal acceptor. It can accept anything because it has antigen A and B and does not have any antibody. So if you give the person A, if you give the person B, if you give the person O, there's no problem because it does not have antibody. Remember that it has antigens but does not have antibody. So nothing can fight anything. But for blood group O, there's a problem. There is no antigen, but there's antibody A and B. So blood group O cannot take from anybody. If A comes in, voila. If B comes in, the problem. If AB comes in, double problem. So O, they are called universal donors. While AB, they are called universal acceptors. So they can accept anything. So this is important for blood donation, which is the day we are celebrating. So when you, so and to make people educated because now blood donation happens almost anywhere, and it's good that you are informed so that you can also inform or educate people who are either taking blood transfusion or who are donating for their patient or for whatever it is that they want to do that. Now, what is the issue? So the second thing there is Rhesus compatibility. Now, this Rhesus is a protein found on the surface of these red cells. Don't forget I said antigens are there, which is the ABO. There's also Rhesus on this. And people can either be positive for this Rhesus or negative. So don't forget I said someone can be blood group A. So someone can be blood group A positive. Positive means that this Rhesus factor is positive. Someone can be blood group A negative. Negative means that this person does not have this this protein, this Rhesus factor. Now, how is it important? Because so I'm sure some of you will have heard that we go to hospital, they say, oh, this person is O negative, person is O positive. It's because apart from that antigen antibody I explained, there's also a system that's also called Rhesus. So this Rhesus can be positive, can be negative. So apart from A, just A, you can be A plus or A minus. Now A plus means Rhesus positive. So somebody who is Rhesus positive, there's no problem. He can get O positive, he can get O negative. But somebody who is negative for this Rhesus, there's a problem. Rhesus means that anybody who tests positive cannot give to this person who is negative. So the person will only have to get a negative Rhesus, either A negative, B negative, AB negative, O negative. And don't forget, because O is universal donor, A negative can only get A negative and what? O negative. So people who test negative cannot get any positive at all. If not, there will be what you call hemolytic reaction. Of course, if they get it at the first time, it will not be a problem because the body will be sensitized at the first time. But the second time, there will be a closer damage. Now, but how is this important? This is important for these issues are more prominent apart from in blood donation, sorry, in blood transfusion. Maybe a patient needs a blood, we give blood to them. It's important we look at it, we consider it, because if you make that mistake, the patient may not survive it. But where it is commonly, is commonly discussed is during pregnancy, which I think that everybody in the world should be aware of. Less, sometimes I'm sure you see people say that they have stillbirths, recurrent, by this certain weeks, 25 weeks, 14, this stillbirth, the child died, or before they give us the child, something happened during the line. Now, a number of those diseases of the new, we call it hemolytic disease of the newborn, stillbirth, where the child looks so swollen, we call it hydrophytalis. Now, a number of these is caused by resource incompatibility. Now, what does that mean? Don't forget I said that this results can be positive or negative. So let's assume that the mother is resource negative and the father is resource positive. Now, in that case, the baby inherits resource positive. So, so if this baby is resource positive, so the mother is resource negative, don't forget, because of this change now, because of this change, now let me explain this to you now. Unlike the ABO system, where the antibodies are naturally occurring, I mean, you don't need to do anything. But for this Rhesus system, the antibodies from this positive or negative only occurs when somebody is sensitized with the wrong blood. So if the person does not receive blood, nothing happens, nothing happens, there will be no problem. But the antibodies are formed when you introduce, for example, now a rhesus positive into a rhesus negative person. The body senses that it is strange. Nothing may happen first, but the body will now build antibodies. So by the next event, if you do that again, there will be a problem. So a mother who is rhesus negative and the baby is rhesus positive. Now, the problem here is that in rhesus incompatibility, the mother's immune system attacks the baby's red cell. Don't forget what I said, it's antibody. It will go and bind on those antigens and what? And kill all of them. So a number of times, the child dies even before they are being born. They born them still, and they call it hydrocephalus, they are just big, and likes like that. So what then happens in this case? How do we deal with this? So when a woman is pregnant, so what we do is that okay, come for your we do what we call blood grouping and genotype. In genotype, we know the genotype, but in grouping, it's when we are doing grouping that we found if somebody is rhesus positive or negative. Somebody who is rhesus negative and is a pregnant woman, once that is found, a number of times people escape it the first time, bah, voila. But the second time, it's a problem. Or if the person has been sensitized even before getting pregnant to an other blood, maybe through transfusion or anything. So the child will not make it. So what do we do to prevent this? Is that the woman was sent to the hospital where they get what we call Roga, and she gets it. That is immunoglobulin. You should call it Roga, but Rogam D, Rogam. That's the common name we call it. Was an is an immunoglobulin. That is given to them before and after pregnancy. And of course, let me not go into that details. But whoever has negative results and is pregnant, of necessity, you must see a qualified doctor so that once they establish it, they confirm it, then they will put an eye. There's a schedule. They give the organ after the child birth within 72 hours. They give the nation. So there are protocols around it which I will not discuss. Once somebody sees that it's an important, the person must take caution. If not, there will just be the occurrence of stillbirth and say, oh, it's a disease, it's a demon somewhere. Whereas it's just ignorance. Okay, and I think I've explained about the ABO compatibility. I've explained the resource. The, Unlike the resource where the child will die in ABO, what you have more is what do you call it now? You have hemolytic reaction, and in the newborn, what happens is the baby can have jaundice. You see their eyes, especially when the ABO it's not compatible, and maybe yeah. So you have this jaundice. So the child can have jaundice, but it's mild. It's mild. It's not as severe as we have in resource incompatibility. So for the ABO incompatibility, yes, you can have that. For example, if a child, I mean, if you have seen, I've seen mothers who are for example now blood group O, or let's say blood group A, maybe B, the child is A, and maybe along the line, there's a cross, because those other ABO, the immunoglobulin, usually immunoglobulin, what we call M, it rarely crosses the placenta. It is the G, which is what you have in razors, that crosses the placenta and sensitizes the mother to the baby. And you have but in ABO, it is mostly M and rarely crosses. It doesn't cross placenta except during delivery. Yes, and of course, you can then have mild jaundice in the newborn. So, if incompatibility is ignored, what are the likely outcomes and the way out? Number one, of course, I've explained earlier on, sickle cell disease is real. So if incompatibility is not respected, we will, love in Tokyo, love in New York, love in Sierra Leone, love in Ghana, love in Nigeria. I say, oh, I love the person so much. If we say love is blind, I don't agree with that. Love shouldn't be blind. Love should have two eyes to see. So I think that before people go too far, it's good to establish this because the consequences are not palatable. Being in hematology, managing sickle cell disease patient, I can see for free. I wouldn't advise anybody to put anybody into that pain. It's terrible. And we've lost a number of patients. Even we lost the patients sometimes by pregnant SS, and we just the PCV down, and the pains is terrible. Of course, some make it, they are doing well, they are better, but I don't think anybody should go through that. So sickle cell disease, that is the SS now. They will have pain, they were exposed a number of times because of sickle cell, this thing, because of this sickle cell, their spleen can, can be out because of the recurrent occlusion. Spleen can be out. So they are exposed to infections, they are exposed to infections, anemia, they can have stroke, they can have difficulty with appetite syndrome. It's a lot of complications. So that I will not be talking about one by one here. Also, if it's ignored, there could be hemolytic disease of the newborn, from jaundice to brain damage or stillbirth. So all those things are important to now to be checked, and also emotional strain of family. So what's the way out quickly? Early testing before commitment or pregnancy. Let's check. Let's not say love is blind. Love shouldn't be blind. Let's check. Let's know what it is. Medical intervention. So, for example, somebody found out that, oh, I'm AS, or no, or maybe I'm Rhesus negative and gets pregnant, and maybe at antenatal or went for a check. Oh, I'm O negative. Even before getting pregnant, the person should be aware and ensure that when it's time to get pregnant, she gets medical intervention so that necessary thing can be done to help out. So medical intervention is key, and genetic counseling. Genetic counseling is also very important, especially people who are not convinced. So, someone that has a result negative, medical intervention, Rogam, go to the hospital, they intervene. Genetic counseling is good. They say, oh, you are AS. So, I've seen a POK, so, oh, they are AS, then we they can work around it. Well, I had to counsel them, so I had to draw it. This is our chances. But it doesn't look as if it is 1/4. It can be 100%. The body can choose 100%. So getting counseling is important so that everybody will make their choice while alive. I mean, in clear consciousness, awareness and education, like what we are doing now, is the way out. So I encourage this, more of this, so that people are aware, people ask questions, and of course, government policies in promoting premarital screening, and in early, what we call it now, promoting premarital screening, and also with our females, there should be antenatal care should be advocated. That's the word. Should be advocated. I mean, it should be noised abroad. Nobody should get pregnant without doing all these things to check to know. Okay, am I positive? Am I negative? If I'm negative, what do I do? Some children come down with brain damage. I mean, and when a child with brain damage is a stress to the family. It's a lot of issues, and I think that's that on that. So, in conclusion, so I can take question. Understanding genotype, risk factor, and compatibility isn't just for medical professionals earlier on. Its knowledge can save lives, prevent suffering, and protect future generations. I jokingly say, and don't quote me anywhere. I jokingly say that sometimes when you have people who misbehave, it's possible because of some brain issues. And some of these brain issues that we have is resulting from this genotype, resource factor, ABO, incompatibility. So we need to save the future generation. People need to be safe from this unnecessary pain. The number of persons on drugs, on narcotics. I mean, we manage patients in the diabetes centers as well as hematologists. We go check on them. All their body are full of needles, choking themselves. Jabbing themselves with needles. All people, some of them come out with terrible sweat. It's a lot, and we can prevent this if this are well done. And we can prevent unnecessary heartaches. Somebody having pregnancy like 5 times, losing the five, and the reason is not because of a demon. It's simply because the woman is results negative. She had received blood before she got pregnant because she had something happened, maybe a fracture or a surgery, whatever it is in that. So every child that comes die. So all these are important. So know your genotype, test your future husband or wife, get tested, be sure of the genotype, and talk to a healthcare professional before marriage or pregnancy. And prevention is not only better than cure. I dare to say that it is often the only cure. Prevention is not only better than cure. I beg to differ that it is often the only cure. All right, so thank you for inviting me. I think let me put a stop here. If there's a question, I don't know if I've made some sense to every one of us. Thank you.
Thank you so much, sir, for the powerful session. I gained a lot, and I trust that our viewers and followers also gained a lot. I think there are no questions in the chat box, but I think I have one particular question to you, sir. Is it is there any advancements in terms of SS children or SS couples? Um, is there anything that maybe in research or anything such that when you give birth to an SS child, there's something that we can do to salvage the situation such that the baby that is being given birth to will not be affected later on in the future? Or is there something about that SS genotype that has been done or is still ongoing in terms of research?
All right. A very good question. Thank you. Yeah. And I skipped that deliberately because I didn't want to bore you guys with a number of scientific breaking. Of course, the world is moving. I mean, people are working around the clock. Yes, what we call something gene editing. Currently, now we
Mm,
can edit genes. So somebody with SS, especially at the early stage, sometimes it's even done. What's the word now? It's even done. It can be done. It's even done in utero. I mean, some people have even gone advanced. They can know
mm,
a baby's genotype in utero. So unlike before that, you have to wait till they are born. But I mean, you can actually know the genotype of a child now, even while they are in, and you can edit. So we call it gene editing using CRISPR. We call it CRISPR. You can check it up online. The CRISPR is a tool for editing. Let me not bore you with your medical jargon, but we use what called CRISPR. So it's gotten uh, from uh, from a genome, so a genome structure thereabout. So it is introduced into the body. It's a lot of complex around it, but that's what we saw. There's gene editing currently ongoing. There's gene editing, and it's being done in some in a number of countries now. Of course, in Nigeria, we've not started doing that yet. But yes, so there's gene editing. So the genes can be edited, and of course, they are. That's number one. They can edit the genes. So editing the genes will change the person genotype. And two, what is more common that we see around is what we call bone marrow
transplant.
stem cell, yeah, transplant, and that is happening in Nigeria. I know of a center in
Mm,
Benin where they do it, and at least I can share the slide with you after this meeting. They've recorded a couple of successes in Benin. There's a special center that they
okay.
collaborate with. So they do bone marrow transplantation, and of course, it has been yielding level of results. But of course, in other countries, oh God, I mean, the result is so
There's
high.
been
But in our
advancement,
country,
yes.
yeah, so the first one that is more common is bone marrow transplantation, but for the other one, which is the advanced one, is now gene editing. So they can I was telling you at the beginning that you are all this AAAS is genetic, is molecular. For example, someone that has SS now or AS, that S is because there's a point mutation on position 6
Mm,
in, of the beta globin chain. Now, so what they do is that they go and edit that. Maybe it's for that reason they will go
did
there
that
and edit it
that chin.
and change it. Yeah, so they change it. So the person comes out with a
That's smart.
normal. Yeah, so they just go to the node because it's molecular. They know the point.
Yes,
It's position
sir.
6 of the beta globin chain. So you just go to that place on the gene on the we call it the coding. They just go to the genetic there, knock it out. They knock out that wrong one, and of course they then put in the right gene that's supposed to be there, and the person comes out to have a normal genotype. Yeah. So hormone transplantation is there, and of course we have gene editing. But let me
Gene
say
editing.
before I close this, even people don't are not able to afford some of these techniques here because of it's very expensive. But I dare to say that people that have regular clinic visits, I mean regular clinic visit, they do better. From my and by God's grace, we should publish something on that very soon. They do better because even before they have crisis, before they have anything, once we check their blood film, we got something irreversible sickle cell index, and we're able to
Mm,
see how much of this sickle cell the person has
has.
morphologically. And when we see
Mm,
that, oh, there's an issue here, we can place the person on drugs. We have some drugs that we use now. There are a number of drugs now, anyway, apart from this now said, a number of drugs are now out. I mean, plenty of them. I can't begin to tell you that are also, in quote, wonder drugs. And there are results now. And it's reducing the level. What kills anybody is the sickle, itself, the sickle cell itself, the crisis itself.
Yes,
That's what
sir.
takes anybody out. So there are a number of drugs now that are reducing the burden. One of the most common type is uh, what's the word now? Is this drug that we give our patient. Um, oh, I think I can't remember now, but maybe if I remember before we close. So there's or let
Yes,
me not
sir.
mention it because someone can go and buy it. So let
Can
me
go
keep it
and
to myself.
procure it and start using
Yeah,
it.
so let me just keep it. This is a live session, so let me keep it. Yeah,
Yes,
but
sir.
it's common. We use it commonly in the clinic. I remember already. So, but let me keep it to myself. So the drug is available and it's cheap now, and people can use, and it reduces the occurrence of sickling, and it produces, instead of having sickle cell, it produces more of the C cells. So it replaces, we
Normal
call it, sorry, let's
cells.
say fetal hemoglobins. It increases the fetal hemoglobins compared to the sickle
Hemoglobins.
cell. Yeah, so the person, they are relatively better compared to somebody. So I'm just saying, follow up, regular clinic visit is also very good and effective. Yeah, thank you.
Okay, sir, there's another question here. It says that do we have to consider the rhesus factor of our spouse as women?
You
Maybe
have
the
to
person
consider
is
what?
already in a relationship and the person is, maybe the lady in quotes is O negative,
Oh,
just like you
okay.
mentioned.
Yeah. Okay. Yes. Yes. Blood group is not or a criteria really to not get married. Maybe someone has negative or positive. That's not a criteria. We have the answer to it already. I don't even get the point. Unlike genotype, we have little or no control because it's molecular. Now,
Yes,
but
sir.
in this resource incompatibility or
Mm,
blood group incompatibility, for example, even though maybe somebody is maybe O negative, all those things, it can be, once it is there, it can be attended to. I don't get what I'm saying now. The problem with someone with O negative or maybe B negative or A positive, even if husband is A positive or mother. Now the issue, where the issue is in childbearing. It has no issue
mm,
on the both of them. And even if there's an issue on that, once you present to the hospital, that's why I explain there will not be any complications at all. So that is not a ground to say, oh, because, oh, I'm negative, oh, it's negative, oh, it's this. No, we don't use that. That is not a ground to say, oh, I must, if it's A negative, I will not marry him. If it's A positive, no. Once you know, that knowledge helps you to prepare when you get pregnant. So because you know already, you will have gotten the program earlier. So, and
okay,
there'll be
sir.
nothing. I mean, there'll be no problem at all.
Little or
Child will
no
be fine.
problem.
Yeah, at
Mother will be
all.
fine.
Except, yeah, everybody will be fine. Yeah.
Thank you so much. I think these are all the questions we have. Thank you so much for coming on this live session. I was really, really impacted. I've learned several things, and I am sure that our followers, people that are viewing us, and people that will still watch this live will have one or two things to learn. Thank you so much. Can we appreciate him in the chat box? Thank you so much, sir,
Thank you.
uh,
Thank
for
you.
having
Thank you. Thank
for
you.
coming on this live. God bless you.
Thank you. It's a privilege.
Thank you guys for joining this live session. I know that we'll definitely be impacted in one way or the other. So do not keep this knowledge to yourself. Share it with people that you know. People need to know about genotype, ABO, and resource compatibility. There is a slide on it that is shared with us. It is on our general page on WhatsApp. I know most of you are on the page. I can just also share it with you on our next live session. So please stay tuned. We'll have another webinar coming up next month. So I want to see all of you. Please invite one or two people to our next webinar series and to get updated on health talks, lifestyle, many other things that we do on this channel. Please subscribe. Please subscribe and refer us by sharing this link. Thank you all so much. I'll see you next time. Have a great night rest. Bye.